Hello everyone, I'm Jahnavi Phanidhar. I'm from India and I'm working under Dr. Bernard for the month of June. I'm presenting the topic of electroencephalography or EEG, which is a common diagnostic method which we use in every neurology department. And that is why I chose the topic for my presentation. Our objectives for today are to go through the preliminary assessment, the recording system for which we use a EEG, the interpretation of EEG, the specialized techniques we use for while conducting an EEG, and the pitfalls of the EEG. In the preliminary assessment, the patient shall be advised to have regular sleep on the night before. No psychoactive substances such as nicotine, caffeine, or stimulants shall be used. If he is using any psychoactive medications, he can use them the day before, but not on the same day as EEG. It is usually conducted in the morning after a light breakfast. The brief interview shall be conducted before the study to confirm the same. The room shall be calm and painted in light pink in which the EEG is going to be conducted. For the recording system, there are two components, the electrode placement and the montages. In the electrode placement, we can see here the diagram showing two lines. One is this vertical line connecting nasion to the anion, and the second line connecting the two preauricular points. And we have two circles along the lines. The regions are designated as frontal for F, C for central, T for temporal, P for parietal, and O for ocular. And there are also auricular regions A. And the electrodes are numbered with left side have the odd numbers and the right side will have the even numbers. G is used for the electrodes on the sagittal line and P is used for pole, frontal pole 1, for example, FP1. This is the international 1020 system, which is commonly used for the electrode placement on EEG. This is a figure showing the distance from the midline or coronal suture, showing the 20-20-10 for the electrode placement. There is another more extensive electrode placement method, which is called the international 10-10 system, which bypasses some of the difficulties faced with the 10-20 system, but it is not commonly used. Montages, there are two different types of montages that we use. First is the referential montage, which uses a common reference electrode for measuring the potential of all the channels. And there is another type of differential montage called common average reference montage, in which we use the average of all electrodes to create a baseline, which we subtract from each electrode that we are measuring. And there is a Laplacian montage, which uses the average of the closest electrodes to the electrode that we are interested in, and weighted average references where the electrodes are weighted according to the potential. There is another montage system, which is a bipolar montage, which is basically using two electrodes for the measurement. It can be along the anterior posterior longitudinal axis or the transverse axis. There are specific types of bipolar montages that are used within the institutions, and channels are basically the channel that we are interested in, which is basically two electrodes or an electrode and a common reference electrode. You can see a referential montage here, which uses the auricular electrodes as the common reference for all other electrodes. And this is a bipolar montage in which we can see that each electrode is used as a reference for the previous electrode. Now this is a normal EEG, which shows the electrodes and the channels. The channels are depicted by the first electrode and the second electrode here, and they are listed on the top left. And we will have a scale showing the magnitude of the waves and the time axis. For the interpretation, we will go through the waveform characters, wave distribution, wave localization, approach to EEG interpretation, and patterns. So the waveform characters, there are positive and negative deflections. Positive deflection is taken as the downward wave conventionally, and the negative deflection is taken as the upward wave on convention. Background activity is defined as any activity that is outside of the interest of the interpreter. Baseline is defined as an imaginary line that goes through the normal rhythm that doesn't interfere with the part of the study that we are interested in. Attenuation is decreasing the amplitude of the waveform that we are interested in. Monophasic wave will have only one wave, one peak, and the biphasic wave will have two waveforms in the opposite direction. They can't be in the same direction. Then they will be considered as two monophasic waves. For the triphasic wave, there will be three waves, and each one shall have opposite polarity. A complex is a waveform which can be biphasic or triphasic or polyphasic. In terms of polarity for the triphasic or biphasic or polyphasic waves, we use the one with the lowest amplitude as the polarity of the waveform. And there are waveform characters, which we use to use them as spike, which is basically a wave with less than 70 millisecond duration, sharp wave, which extends from 70 to 200 milliseconds, and a slow wave, which occurs for more than 200 milliseconds. The rhythm of the wave is a regular replication of the wave, which we see in the regular replication of a series of waves, which can see in the EEG. A pattern is said to be regular if the waves are a similar morphology and similar periodicity. Periodic waves are those which repeat on a timely basis along the EEG recording. Replication is the same as when the waveform with similar morphology and similar characters is repeating on different parts of the EEG. Evolution is an important characteristic of the waveform, which shows increasing amplitude or decreasing amplitude, increasing frequency or decreasing frequency of the waves along the EEG. And we can name the we can see the distribution of the EEG wave and characterize them as focal, hemispheric, bilateral, or generalized. Focal is basically when it is present on only one electrode or the nearby electrodes within the immediate distance of it. Hemispheric is when it has more than two inter-electrode distances, and bilateral is when it crosses the coronal suture but not the sagittal suture. We will call it a generalized wave when it crosses both the coronal and sagittal lines. This is the wave localization in a referential montage, and we can see that there are three deflections here, and the one with the greatest amplitude is taken as the focus of the ecology in a referential montage. In a bipolar montage, for determining the focus of the ecology, we consider phase reversal. At T4 here, we can see that when it is combined with F8, we can see it's a positive wave because T4 is negative when compared to the F8, but when compared to the T6, it's a negative wave, showing that the T4 is negative when compared to T6. So the T4, where the phase reversal is happening, is the focus of the ecology. This is a bipolar montage with extended focus, broad focal discharge. Here we can see that the phase reversal is happening, but over the entire F8 and T4, which both have almost the equal amount of negativity or the equal amount of positivity. So the approach to EEG interpretation are, we have to consider the EEG and see which features are present in the EEG activity, and use the features to determine which patterns may be the representing this unknown activity. And we use these patterns and consider the patient's context and decide which patterns may be useful for differentiating the diagnosis. We will go through a list of patterns, the common ones. There are many other patterns, but due to time constraints, we will go only through a few. The alpha rhythm is the one with frequency of 8 to 13 hertz. It's posterior dominant, which is commonly seen in the posterior dominant, so commonly seen in the occipital area. It has an amplitude of 10 to 80 microvolt, and it is most prominent with eyes closed and relaxed. It can be suppressed with eyes open and when we are asleep. Absence is seen in 2 to 5% of the population, and it's common and it's inherited in an autosomal dominant way. And those who are blind from an early age can't see, won't have an alpha wave. This is an EEG depicting the normal alpha rhythm, and we can see the alpha wave with the alpha rhythm in various parts of the EEG, and most evident in the occipital area here, O1, O2. This is called a Barnard phenomenon of the alpha rhythm, when the alpha rhythm of one side doesn't get blocked while asleep. We can see that the alpha rhythm doesn't get blocked on the right side of this EEG, and the unblocked side is the abnormal one. There can be some asymmetry in the alpha rhythm activity as shown in this EEG, and it is normal as long as the one with the lesser amplitude is within the is greater than 50% of the normal one. Usually the right one has greater amplitude when compared to the left one, as shown here. The left one, the odd numbers O1 has lesser amplitude when compared to the right alpha waves O2. There is a phenomenon called alpha squeak, which happens when the patient falls, wakes up, and when he wakes up and blinks his eye, there will be a transient alpha wave morphology with low amplitude and high frequency, but after half a second or 1 second, it increases to the normal morphology and becomes normalized. We can see that this is the eye blink artifact, and after that there is a decreased amplitude and increased frequency, and it slowly normalizes to the normal one. There are alpha variants where the slow variant of alpha, which occurs in 5 hertz, the normal being the 8 to 13 hertz. This is normal. And there is a fast alpha variant where it can happen much faster, as shown here, which is around 18 hertz. And when the amplitude is less than 50% of the normal one, it's called an abnormal alpha rhythm, and you can see that here. It's less than 50% of the normal one. And when the patient is drowsy, the alpha rhythm, which is occipital predominant, extends to the temporal and the frontal areas possibly. This is called generalized alpha activity, which is seen in comatose patients. You can see alpha waves through all the electrodes or the channels that we are observing, and not just the occipital waves. Beta rhythm, it has a frequency of greater than 13 hertz, and it is normally seen in the frontal and central areas. It has increased activity with medications like benzodiazepine, barbiturates, and sedatives, and decreased activity with cortical dysfunction like infarction, abscess, tumor, etc. And increased focal activity can be seen with cortical dysplasia, tumor, ectovenous malformation, etc. The skull defects after a surgery or trauma can cause focal high amplitude sharp beta activity. This is called a breach effect, and we will go through it after a few minutes. We can see the frontal central beta activity in this, which is high frequency, greater than 13 hertz, and low amplitude when compared to the alpha waves. We can see the waves here, predominantly around the central region. This is the generalized beta activity, and the most common reason for generalized beta activity we can see here are the barbiturates and benzodiazepines. It can also be seen with certain conditions like hypothyroidism and even hyperthyroidism. breach effect is basically an intermaking a small, it is limited to the small field, and it has a sudden burst effect because it happens when the skull is open due to either surgery or trauma. We can see this in the left central region here and here. Theta rhythm goes through a frequency of 4 to 7 Hz and is present in healthy adults, however not in excess, and it increases during drowsiness. It is observed to be associated with euphoric states and related to intoxication or exercise. We can see a theta rhythm here, which is most prominent on the sagittal C central electrode, which is the slow wave. It's 2-second duration, and there is slight left side dominance here, like we can see. This is called the polymorphic theta activity, which in which the amplitude and the frequency will have an overall asymmetry, and it is diffuse. It is present normally in infants, but in adults, it can be the normal drowsiness or even encephalopathy. It is for non-specific encephalopathy, which can be reversible or irreversible. Reversible being causes being hypothermia, metabolic disease, or sedatives, and irreversible being any severe encephalopathy like infarction, tumor. This is the rhythmic mid-temporal theta waves. This is, we can see the rhythms, they are repeating in succession, and they are repeating again and again in the channels. This is considered a normal variant now, but it was thought to be of related to epilepsy at one point. Delta activity, which is less than 4 Hz frequency, and individual waves will have a duration greater than 250 milliseconds, or any combination of waves that has a duration of greater than 250 milliseconds. It commonly occurs during the non-REM stage 3 and during the encephalopathy. This is the polymorphic delta activity, which we can see as diffuse slow waves. They have very low frequency and high amplitude, and we can't see any other waves here. This can be happening in non-REM case or the cortical dysfunction, any cortical dysfunction. There are variant of theta waves called the Zeta waves. They are seen in acute cerebral lesions. They have a Z shape like shown here, and they have been shown to be very specific for seizures, tumors, hematoma, and focal trauma. The frontal intermittent rhythmic delta activity, which is which can be considered shortly as IRDA. It's a highly non-specific, and but it can show that it can be any focal or diffuse abnormality, and it can be anything like toxic, metabolic, congenital, or degenerative abnormalities. We will go through some EEG patterns that will relate to sleep. They are the sleep spingles. They are a burst of rhythmic activity at the midline and near the vertex, and commonly seen in non-REM stage 2 and stage 3 sleep. They usually have a frequency of 11 and 16 Hz, and they begin and end abruptly, like a burst. During the light sleep, they are mainly over the vertex or the central part, and they have a higher frequency, 13 to 14 Hz. But when we progress to the deep sleep, they move anteriorly towards the parasagittal and midfrontal parts, and their frequency decreases to 11 and 13 Hz. They are theorized to be role in memory consolidation, and it was proven with functional MRI that it has a role in memory consolidation during sleep. Their presence in a comatose patient indicates better prognosis, and when it is asymmetric below 2 years of age, it's normal, but above 2 years of age, when it's asymmetric, it shows that it has thalamocortical dysfunction. We can see the sleep spingles here, which are most prominent over the central region and parasagittal distribution. So as they are a spingle, it should have at least triphasic wave, which will have a negative, a positive wave, a negative wave, and a negative wave. K complexes are another ways that are seen in the stage 2 and stage 3 of non-REM sleep. They are transients with a vertex localization. They are polyphasic and usually have 2 or 3 phases. Most commonly, it occurs immediately precedes a sleep spingle. There are different definitions that incorporate that there shall be a sleep spingle after it to be defined as K complexes, but there are 2 standardized definitions that doesn't require the sleep spingle, and that is what is commonly used. We can see the K complex now. A typical K complex has a low amplitude first wave and a first negative wave, and then a positive wave and a high amplitude third negative wave. These are another waveforms that are commonly seen in sleep. These are the vertex sharp transients. They are a surface negative sharp wave, like for surface negative sharp wave, which means it will have a negative or upward stroke, and they are seen near the apex of the head. They are the first EEG pattern to occurring drowsiness that are specific for the sleep. They most often occur spontaneously, but may also be evoked by sudden stimulation. We can see the vertex sharp transients here in the central region between the C3 and C4 electrodes in the triphasic fashion. They have 3 peaks, 2 negative deflections and 1 positive deflection. Now we will go through the equal epileptic form patterns, which are patterns on the EEG that we observe while the patient is in seizures. For the focal onset seizures, the patient, it is simply the seizure, the EEG pattern that the patient has while he is seizing. There are 2 characteristics that are expected. They are almost always stereotyped across seizures for an individual patient, and they typically involve evolving rhythms, evolution that we talked about before, or repetitive waves. In some cases, the evolution might not be seen, and they can be seen as desynchronization or regular repetitive spikes or regular rhythm slowing, but it is most commonly seen with focal motor seizures without cognitive impairment. Focal EEG waves do not differ in their EEG pattern without, depending on the local focus or evolution. We can see a focal seizure here. The case mainly at the T2, T1 channel and the F8 channel, F8, T4 here, and this can be seen over the next three slides. If we follow the T2 and the F8 channels, we can see how the amplitude is increasing and the frequency is decreasing and evolving. The waveform is evolving, and finally the waveform has been increasing to a much higher frequency and amplitude, as we can see in this image. And now we will go for the ictal patterns for generalized onset seizures. They almost always have one of the 3 types of generalized or bilateral patterns. They are generalized paroxysmal fast activity, which have a very fast frequency, high fast frequency in the beginning and a low amplitude, and this gradually becomes with something with low frequency and high amplitude as the wave progresses. And there is generalized spike and slow wave complexes. They occur in succession, and they have a long duration. They are usually of triphasic morphology, and they have a polyspike initiation. Electrode decrement, as the name states, is seen when there is a sudden upgrade decrease in the entire potentials, the electric potentials of over diffusely of the channels. Generalized onset seizures typically end with either abrupt resolution without any evolution, and evolution in waveform in frequency, or disintegration of the pattern. This is an ictal onset seizure that we can follow over the next 3 slides, and it can be seen mainly in the it can be seen in the form of polyspikes in these regions, and as it is generalized, we can see it cover across most of the channels. And as we can see, as it progresses, the waves increase with frequency, and increased amplitude. And finally, we can see this generalized tonic seizure over the entire time. Here we can see an absence seizure, which shows the generalized spiking slow wave pattern in three hertz waves, which are commonly associated with them. They are characteristic of absence seizures, which are most prominent in the central region. This is the electro-decremental onset seizure. We can see after the spike that there is a sudden decrease in the amplitude of the electrode channels here. There is another seizure of Carrick, but it has a slow wave. It is followed by slow wave that is not the electro-decremental seizure. Now we go through the incorrectal epileptic form patterns. They are the most specific for diagnosing, most specific and sensitive for diagnosing epilepsy. They should be having 4 characteristics. They should be paroxysmal and distinct. There should be an abrupt change in polarity, and there should be each glancing wave should be less than 200 milliseconds. The discharge must have a physiologic field with the discharge recorded from more than one electrode, and it should not be a pattern of known benign variants. We will list some known benign variants afterwards. Most of the incorrectal epileptic form discharges have a negative polarity of the scalp, and they are followed by a slow wave. Although these are not criteria, we can use them to identify them. Focal incorrectal epileptic form discharges. They have 4 characteristic features. They are sharply contoured, electronegativity on cerebral surface, like stated before, and disruption of surrounding background activity. The field extends beyond one electrode. We can see here that there are 2 temporal lobe IEDs there are placed around the T3 region here, and there are focal seizures showing a prominent spike component and a higher amplitude when compared to the background activity. These are the temporal incorrectal epileptic form discharges. We can see 5 components here: 1, 2, 3, 4, 5, and each of them are polyphasic, and they are repeated. They have a low. They are repeated along the EEG strip again and again. And this is a bilateral independent incorrectal epileptic form discharge. We can see that there are epileptic form discharges, but they are independent of each other and they happen bilaterally. They do not occur at the same time over all the electrodes, and that is why they are called bilateral. Rolandic incorrectal epileptic form discharges are a specific type of discharges that are seen with a specific type of epilepsy called benign Rolandic epilepsy of childhood. We can see that they have a characteristic triphasic waveform here, and they occur with the transverse dipoles, like the electrodes that are on the same paracoronal lines or the transverse line. And they occur in quick succession, which are a characteristic of the Rolandic seizures. And there are other incorrectal patterns like epileptic form discharges with prominent slow waves, like we can see here. In multifocal independent spike discharges, as we can see, there are independent spikes that are occurring in different foci, and they are independent in the sense that they don't occur at the same time. And the incorrectal epileptic form discharges for the generalized seizures, they typically occur as a complex with sharply contoured waves and is followed by a slow wave. But they occur as bursts of success. They may occur as bursts of successive spikes. Then the sharply contoured wave is a spike or polyspike. The overall waveform is called spiking wave, spiking dome, and darting dome. Spiking slow wave complex usually has short duration than spiking slow wave complex, and classically repeats as the train with frequency of waves with frequency of 3 to 4 hertz. This is a generalized incorrectal epileptic form discharge showing the spiking slow waveforms. Here we can see the spike followed by the slow waves. The slow spiking slow wave incorrectal form epileptic form discharge is another epileptic form discharge seen with generalized clonic seizures, and we can see the slow spike and the slow waves followed by along multiple electrodes. Here we can see a diffusely slow background activity that is interrupted by 2.5 Hz regular slow waves with spike notches in their upslopes. These slow spike and slow wave discharges are produced by slowing, and this is called as hypsarrhythmia, a specific type of incorrectal form discharge seen only in infants below 2 years and 2 years of age. But it can be rarely seen in neonates also. It has it's come from the Greek word high and erythemia, which called hips erythemia, and it has a very high voltage and high amplitude, which we can see here. It's usually between 200 to 400, but it can be as high as 1000 volts. And as we can see here, the potential is 750 microvolt, which is more than the rest of the EEGs which we compared till now. There are other patterns, benign, a lot of benign patterns, some are pathological patterns, but we don't have the time to discuss it. While recording an EEG, it is common to encounter artifacts which can be due to heart motion, heart pulse, or electrode motion, or salt bridge phenomenon, eye motion, muscle motion, and the environmental aspects like noise from the other devices, etc. We can see here with a focal onset seizure with temporal lobe followed by generalization, which is in the next page. We can see that the same seizure we can't interpret because of the muscle artifact obscuring the entire EEG study. It's because of the generalized tonic-clonic seizures which have created the muscle artifact. There are specialized techniques that we use to activate the seizures. They are the routine ones that used with every EEG study are hyperventilation and photic stimulation. There are other activation techniques, including sleep and both sleep and sleep deprivation. Specific electrode placement includes placement of the electrodes in the sphenoid bone, ears, nasopharynx, etc. And there are other methods of limiting electrode montages also. Hyperventilation increases the rates of generalized discharges in childhood and childhood absence, epilepsy, and other generalized epilepsies. But it has been shown to be less productive in partial epilepsy. It's very effort dependent, so the yield may vary according to the effort of the patient. The photic stimulation, photic stimulation is another common activation technique that is used in almost every EEG study, and it induces epilepsy in people with idiopathic generalized epilepsy, and sometimes in those with frequent focal seizures arising from the occipital lobe. The pitfalls are a normal EEG doesn't always exclude the epilepsy, and repeated EEGs or a long-term study like a 72-hour EEG might be required. Even then, we can't rule out an seizure disorder with EEG. And abnormal EEG is not always characteristic of, cannot always be called as an, cannot always be used to diagnose a pathology, because many children, 2 to 6% have an abnormal EEG normally, and a far lesser percent of adults, around 0.5 to 1, have the same abnormal pattern when they are healthy. And there are variations in interpretation depending on the interpreter. These are the referring books. Thank you.